We're starting up. The slides are up. We talked about the degeneration of the valves in a previous talk, but we thought that perhaps we can, okay, let's see where we are. No problem. So in general, the subject has been generated by the aspects of the nature of the complications or the problems around TAVR that indicate that there may be bleeding events and ischemic events, and particularly the ischemic events initially dominated by the strokes due to the alarm set forth by the first initial TAVR trial versus surgery, at the same time realizing how those are intertwined with a chronic and elevated atherosclerotic risk in these patients, as well as with the atrial fibrillation that is also prevalent quite a bit in this population. And the antithrombotic therapy, when you jump to say, you know what can we do about that? Well, the two kinds, antiplatelet and anticoagulant, and very soon we realize it's not only the patient-related factors that I told you, but maybe there may be some valve-related factors as well, such as the metallic stent endothelialization, various other things, the restrictions in the expansion of the valve, and what that may mean for the neosinus or even for the valve leaflets themselves. So in general, one can say that if I have to analyze the problems of the stroke, that's how it all started, is either aortic arch atheroma or the onset AFib, you can see a like clot, or you can have some leaflet thrombosis that are quite excessive, as you can see here by this echo. In the predictors of cardiovascular events in general, you can see that atrial fibrillation is remarkably incredible risk, just as is female sex, chronic kidney disease, and the learning curve, of course, in every study. Things began to change quite a bit when we were using the 4D CTA. The 4Ds, they call it the CTA video, essentially, that sees the aortic leaflets opening and closing throughout the cardiac cycles. And you can see very clearly here that in many of these valves, all sorts of valves, surgical and transcatheter valves, and all sorts of leaflets, maybe one, maybe more, can be obstructed from opening by something that blocks the hinges of the leaflet, and that could be clot or could be degeneration, could be anything, quite frankly, but this was happening early on. And it's called the hypoattenuated leaflet motion, and initial reports indicated that if patients are anticoagulated quite heavily, actually, at that time, and purely empirically in different registries, the normal functionality appearing quite a bit. And actually only after you completed the cycle of the therapeutic trial of anticoagulation can you say that in retrospect this was all clot. It's very difficult to kind of know from a get-go that this is clot or not. But obviously, the temporal association with the initial procedure and that it got dissolved by the blood thinner makes a definition that is a clot. So we really need the therapeutic criteria to establish the diagnosis at that stage. At the same time, we realize that, and we know from the valve trials, that the bleeding early as well as late has a lot of problem in association with mortality. So in the background, in general, means be careful when you start using blood thinners. So this is exactly what has been the story of the antithrombotic therapy after TAVI, the risks between thrombosis and bleeding, and how do we reconcile those. In the 2020 and 2017 guidelines of the United States and Europe, you can see mostly empiric guidelines, small trials, primarily in the antiplatelet. I'm going to show you before. The simplicity seems to be underlined in the Europeans, and in the Americans, guidelines, 3 to 6 months of dual antiplatelet therapy is favored. The anticoagulation tends to be avoided routinely for a good reason, as we will see. The European guidelines went a step ahead in 2021 in the summer and oversimplified the single antiplatelet therapy recommendation currently for every patient. The antiplatelet trials are confounded thus far by the fact that it's a significant problem, affects all patients, and the trials are tiny. And this is one of the bigger trials, has about 100 patients per group. And interestingly, it's not, although one can say, okay, you follow the patients for a few months, the patients are also treated before the procedure by the clopidogrel, which is the investigational arm here, the aspirin and clopidogrel versus aspirin. Everybody gets it beforehand. So it's not a purely discharge medication the way we presume or we talk in this subject nowadays. At that time, we were starting the patients before the TAVR. Again, it was a mentality that a stroke may happen during the TAVR, and you got to do something to avoid it right then and there. So all of those, you have some bleeding in the beginning. But interesting enough, the stroke didn't seem to be impacted a lot, if at all, with this in this study by the aspirin alone simplified aspect. We experimented in a large Galileo trial. It was over 1,500 patients, 1,644 in fact. Combination of the antithrombotic therapy was in the fashion at that time. Again, there was a hype about the strokes and what could happen with the leaflet clots. And the experimental arm was a low-dose rivaroxaban because we were very sensitive about the bleeding risks, and combination with aspirin. At the bottom row, you can see the dual antiplatelet therapy. And after 3 months, one medication was dropped by either arm and continued as monotherapy from then on. If anything, the trial at that time was heavily criticized, I should say, not heavily, by the fact that rivaroxaban was too low, and therefore this would have no impact at the valve leaflet, perhaps, that everybody seemed to be concerned extremely at that time. And with any trial, one can say this trial came up with very interesting findings. On the right side, an expected finding, which is a trend towards higher major bleeding in the rivaroxaban arm. And again, this is only a trend because we use a low dose. On the left side, an unexpected finding, an increase in MACE, primarily driven by increase in all-cause mortality. That's coming back to the hypoattenuated leaflet motion. At that time, it was very difficult to even it was a beginning of the field, the initiation of the field. We had a great collaboration with Lars Sondergaard's group in Denmark as a core laboratory, and the lead author is our colleague Ole Debacker in our paper together, and presented a very clear classification of how exactly those were analyzed. And you can see grade 0, no clot. Grade 4, the cup is almost full with all this dark blue material, and that's a lot of clot. And grades 3 and 4 are really, those are I would say very obstructive, and the others are less. Interestingly, and despite the criticism of using a low dose rivaroxaban, there was tremendous efficacy in preventing either the leaflet thickening, which is any leaflet thickening, or the significant grades of reduced leaflet motion that I show you, grade 3 or 4. And I'm glad to have many investigators who have the USA investigator lead, Dr. Herman, with us today, and many others participated in this trial that are in this forum. So although we had a great success, and perhaps not so anticipated in the leaflet spot, somehow there was an unexpected finding that there is a late increase in mortality for unclear yet reason, and therefore the routine anticoagulation with rivaroxaban doesn't make sense. But at the same time, we do know that if you want to be efficacious about leaflet thickening or address that, you really don't need a very high dose of anticoagulation. That's a very important aspect to think about. The Dutch investigators took a different pathway. Their pathway of preventing the clots, the procedural clots, was to start the medicines ahead of time and not interrupt them at all for the most part of this study, the popular study. So whatever category, and they're treating all patients with uninterrupted oral drugs, and they just randomize them according to whether they need anticoagulation on the right side or not. And you can see the different pathways on the bottom. Again, all started beforehand and continued throughout. No wonder there was a significant bleeding perioperatively with the clopidogrel arm. The lines are remarkably parallel after that, so it doesn't seem to be a penalty for clopidogrel after the discharge. Interestingly, the therapies were given for for a limited period of time, 90 days, and then the patients were followed up on whatever regimen the doctor wanted until a year. So that we don't really know that we're getting the assigned therapies for a whole year. Nonetheless, in the ischemic endpoint, there seemed to be not much difference at 1 year. Interestingly enough, the two curves seem to be slightly different in that the red curve seems to be flat after a few days, and the blue curve, which is the asthma alone, seems to have an accumulation of event over time, something that no other trial has studied to essentially follow the patients for longer than the assigned random treatment. So I wonder if that's a true effect, that true issue of the asthma monotherapy that has to be studied further, or is just a play of chance of how the events occurred or documented in this study. In the anticoagulated group, and again, for the most part in this study, uninterrupted anticoagulation, a lot of bleeding from a get-go. 10% on day 1 had major bleeding in one group and 20 in the other group, and clearly the clopidogrel had a lot of bleeding also as well here. And the ischemic endpoint of those, it really didn't matter that much. But on the other hand, let's just remember that no other study, and I would say in most centers, are not practicing the TAVR while on uninterrupted oral anticoagulation routinely. One of the newest studies is the ATLANTIS trial, came out right before the guideline update in last year. And again, they had features like the popular. They had 2 strata, all patients, 1 stratum with anticoagulation on the left and 1 stratum with antiplatelet on the right. The interesting part was the study arm was the same for both. There was a full dose anticoagulation with apixaban. So that was an innovation in the design, and they followed exactly the Galileo pathway of assessing, starting the therapy after the procedure, essentially only studying the post-procedure, post-discharge, one can say, essentially, course of those patients. Overall, not much difference, and particularly if you take away the CT-driven valve imaging endpoints, the pure MACE, you can see 133 events with apixaban, 121 with standard of care. But from our point of view, we need to understand better what kind of patients were treated. No difference, as I said before. And in the oral anticoagulation, the study is small, 200 patients per group. Not a lot of difference in any of the endpoints, apixaban versus warfarin. In the stratum 2, with no indication for oral anticoagulation, which is very similar design as the Galileo trial, interestingly, the observation that was unexplained by the Galileo trial of increased mortality was repeated again here. So it's actually not really explained, but it may be not fully explained, but it's probably most likely true, because you have 2 independent studies reaching the same result. With either an intermediate or high dose anticoagulation, you have higher death, higher non-cardiovascular death, and also some few more cardiovascular death events. Now, in the sub-study, in the imaging sub-study, is very, very interesting. The findings here is that overall the result is neutral, but this is because there was an effect in the against antiplatelet, but not in the but actually somewhat excessive events of CT imaging clots, 9.5% with apixaban versus 5.5% with Coumadin. So one can say the overall result was end up neutral, but clearly there's some efficacy of the full dose anticoagulation with apixaban in preventing the clot. I think that's expected as full dose anticoagulation anyhow. What this study did show is that the presence of a lot of clot in the valve had nothing much to say about future strokes. That's a very important pathway. The final trial I want to get your attention to is the Envisage TAVR. That's exclusively AFib. That's a large number of patients, 700 per group. Doxaban versus vitamin K. About 50% receive antiplatelet therapy per the decision of the clinical doctor. And you can, the cutoffs and the indications for dose reduction are listed here, pretty standard per the package insert of those drugs. Overall, the study endpoint was positive. They met non-inferiority for NACE, all-cause death, MI, stroke, systemic thromboembolism, valve thrombosis, or major bleeding. You can see on the left side. On the other side, on the right-hand side, you can see that the major bleeding, particularly after the 1 year, seems to be higher with the edoxaban versus the vitamin K. The ischemic stroke and all-cause death, you can see those curves, overall non-significant, although numerically lower with a red line, which is the edoxaban. If someone going to look a little bit more into the bleeding aspect, the lower doses of edoxaban, 30 milligrams versus 60 milligrams, seems to have less bleeding issues as expected, and also the patients with the specified oral antiplatelet therapy were those, about 50% of the cohort, as we said, where those differences in the bleeding were most accentuated. So avoidance of antiplatelet, the utilization of a low dose of edoxaban would be, I would say, one can say, the clinical derivatives of this trial. So in conclusion, I would like to indicate that in general, we continue to have limited evidence, and thus far, we have several trials, not very large, but several for sure. We know that even low-dose anticoagulation is effective against the TAVR-lifted thrombosis. We know that when another indication for anticoagulation exists, a monotherapy is most reasonable option. We know that there is no role for routine anticoagulation when no clear indication exists. We know that the widespread clopidogrel loading before the TAVR is no longer required and has been largely abandoned. And we also know that the prolonged combination of the thrombotic regimen should be avoided. And if they deem necessary, they have to re-examine this necessity, have to be re-examined at every doctor's visit. So until then, we have a tailored approach that we follow according to these 5 things we know and all other things the patient characteristics have. But most importantly, we require more studies in this area to develop a rational and customized strategic approach. Thank you for your attention. Thank you.